In this next half hour or so, I will discuss clinical interviewing and pain assessment. So the objectives of this talk are to talk about the essential components we need when conducting a clinical interview to assess pain, and really outline the necessary information to complete a pain assessment in order to guide our treatment. Let's start with a case study. DG is a 60-year-old man who's one day post-operative from a colectomy from a recent diagnosis of colon cancer. He reports his pain severity is 9 out of 10. He's demanding, lashing out at nursing staff. He's receiving oral opioids, oxycodone, 5 milligrams with acetaminophen, 325 milligrams every 4 hours as needed for pain. His blood pressure and pulse are elevated. He's diaphoretic and nauseated. So let's start with this clinical interview. If we don't have the necessary information, we can't treat the pain. So we want to set the interview agenda. What are the patient's main concerns? And what are my concerns as a clinician? We want to allow the patient to tell the story, and trying to do that without interruption, which can be really difficult considering the pace that we all work, especially in acute care settings. But we want to, during this interview process, clarify the patient's story. We want to gather the necessary information related to the pain-related problem and a shared understanding of what the patient's telling us and what we're hearing. And then it really should be a shared decision-making where we can negotiate a plan, but then we can educate at the same time. So it's important during the interview process to use empathetic responses. We can inquire. We don't assume how a patient feels. It's the patient's pain, not yours. You want to identify feelings and respond with acceptance and understanding. Avoid saying, I know how that feels, unless you've actually experienced it yourself. You want to be able to be present with the patient. This is so hard today when we have cell phones going off, smart text, pagers, you might have your computer with you, but try to be present with the patient. So many times when I've had patients in the clinical setting, they'll talk about how the person who's seeing them never even looked at them because they were taking care of the computer screen, not the patient. You want to express interest in what the patient's telling you. It helps you develop a trusting relationship. And try not to interrupt when telling their story. It's really hard. Use questions such as anything else to elicit further concerns. So DJ goes on to tell you he has a history of chronic neck pain and now has the colon cancer. He's got pain to the surgical site in the abdomen, but also has this chronic pain in the neck, which radiates to his left arm. He's now rating his pain 10 out of 10 when you're talking to him. He does have a history of substance use disorder, and he takes Suboxone, which is buprenorphine with naloxone, 16 milligrams daily to treat the pain and substance use disorder. However, he didn't tell his providers on admission. His records weren't in our system, and he was worried about discrimination, which is a real issue for people that have substance use disorder, to worry that they're going to get inequitable treatment, because many times they are. He tells you he's having difficult sleeping during the pain. He's really worried about his work and finances now with the new cancer diagnosis. He's anxious and depressed, and there's tension with family members. So how do we go about our pain assessment? Why do we even do one? We want to understand what's the underlying pathology, and we correct the pathology if necessary. Is it trauma? Is it heart disease, cancer, or diabetes? Is it an environmental thing, someone who's developed pain from workplace environmental statuses? Or what are the other contributors? Emotional, psychological, and environmental. Think about DJ. He's got a new diagnosis of cancer. He's got comorbid substance use disorder. He's worried about discrimination. He talks about tension with family members. And we want to obtain the needed information so we can design an effective treatment program and also set realistic goals. I've often have been able to say to patients, I don't have a magic wand. I can't tell you that I'm going to actually relieve all of your pain. And we can use different tools. I tend to use the OPQRST-UV. Now, the PQRST was actually brought forth by Twycross in 1978 when he was looking at cancer-related pain. Other people have added the O, the TUV, but really, it's really going to be talking about, or we're going to look about, is this acute or chronic? Is this going to be something that makes it better or worse? What type of pain is it? Where is it? How does it radiate? How severe is it? When does it occur? What does the patient understand? And what is the value? And we'll talk about each one of these now. When we think about the onset of pain, so we're looking at, is this an acute or is this a chronic pain? Acute really, we talked about in number 1 module, secondary to trauma or surgery or injury. Chronic, usually more than 3 months or after the expected time of healing. What are the provoking factors? What worsens the pain? Does lack of sleep, position, activity, stress, treatments, certain medications? I have patients with pulmonary artery hypertension that are on intravenous therapy for the pulmonary artery hypertension that absolutely worsens their pain. What are the palliating or the relieving factors? Are they home remedies? Asking about that is important. Over-the-counter medications, prescription, illicit substances. Many people are using cannabis to help their pain, and they might be hesitant, especially if they're in a state where it's not legal, to actually discuss it. Is it physical therapy, activity, or rest? What about other things like integrative options such as massage, acupuncture, or biofeedback? Do any of them help the pain? So what is the quality of the pain? So we're trying to figure out, is this a nociceptive pain, neuropathic pain? Does it have both nociceptive and neuropathic components? Does it involve the organs, the bones, the muscles, or nerves? Is it a syndrome like we see in fibromyalgia, which can cause diffuse pain in multiple parts of the body, hard to actually pinpoint, nothing really will show on x-rays. And so it's important to try to classify the type of pain to help with treatment. So like we've talked about before, you've got your arthralgias, your joint, back pain, pancreatitis, headache, fractures, which are a type of nociceptive pain. Many times people talk about it being sharp, dull or achy, throbbing, versus neuropathic pain, which can come from chemotherapy-induced neuropathic pain, spinal compression, shingles, diabetic peripheral neuropathic pain, HIV neuropathy, which we hear people talking about shooting and burning and tingling, sensitive to touch, more exaggerated pain into touch, pins and needles, bugs crawling, visceral pain, which is hard to really describe when we see people with a bowel obstruction or hepatic distension, but this is discomfort, for example, in the abdominal area, but really hard to describe. And then we can have people that have mixed pain states, like chronic inflammation from autoimmune disease, or nociceptive pain, like back pain with a spinal cord compression with nerve pain down the leg. So where is the pain and where does it radiate to? You would think, like when you say back pain, but back pain could meet anywhere from the neck all the way down to the tailbone. So finding out where that is. I remember a patient once saying they had horrible back pain, and people were assuming it was from the cancer they had, but the pain was in a totally different location, the back, where there was absolutely no sign of cancer. Does the pain move or radiate? So, for example, low back pain with radiation to a leg or foot may be related to a nerve root compression, or you think about someone with neck pain, with pain to the hand or fingers, again, is that compression. People that have abdominal pain that radiates to the back, secondary to, for example, pancreatic cancer, you may often see. Now, pain severity, I think many of us that are nurses, we're used to going in and saying, what is your pain, 0 to 10? I have the no here. I mean, I wish it was one tool we could throw out. I think it's great when we're looking at post-operative pain or an acute pain and we've given a medication, we went to see the response. I think it's damaging when we look at doing it when people have chronic pain states. I want to know, what can that person do? What is their function? How is their sleep? Versus giving me a number. Or if they're going to give me a number, I need to know, what is it now? What's it at its worst? What's it at its best? What is it overall? So you want to explain the use of the pain scale and ask about when it's best and worst. If they're unable, then try to elicit information in other ways: mild, moderate, severe. Obviously, cognitively impaired, we're not going to use it, and you use nonverbal skills. What is the timing? When does it occur? Is it related to a time of day? So, for example, people with osteoarthritis or rheumatoid arthritis, it may be worse in the morning. People that might have chemotherapy-induced peripheral neuropathic pain or diabetic neuropathic pain may tell you it's worse at night. What does the patient understand about the pain? Is there a clearly defined etiology? Does the patient understand the reason for pain? I remember working in pain clinics with a patient would come in with chronic pain, and every time there was a new pain, absolutely afraid that this new pain was related to a new thing like cancer, or that the worsening back pain meant that something was broken. So what is that person's understanding of the pain? And then what's the value? Does it serve a purpose? Now that sounds really strange. Is there a secondary gain? Sometimes we can see this maybe in chronic pain. There may be a secondary gain. Like one of my patients said, I need to stay on disability. If I come off of disability, I will lose my health insurance. I can't work enough to be able to pay for it. Now that's a problem with our system. That's another story. But there might be secondary gain in terms of attention from family members. And so trying to figure out, is there a value to having this pain? So what do we do about patients that are unable to report pain? Now, I can't go through or won't go through all the different nonverbal skills. It really depends on what you use in your institution, but you want to use some type of tool. The behavioral pain scale or the critical care pain observation scale really were developed for use in critically ill and ventilated patients. The FLAX scale was really designed for the pediatric population not able to report pain, but it has been studied in nonverbal adults. I worry when it's used in adults that are cognitively impaired but may not be nonverbal, or using it when people are sleeping. There is the nonverbal pain scale that was originally used in the burn unit. It was adapted from that FLAX scale for use in adults. Now, one that I'm going to show on the following slide is this multidimensional observational pain assessment tool that measures pain and physiologic pain indicators across palliative care settings. So it may be good to use for our cognitively impaired or non-communicative patient in a palliative setting. There's also the checklist for non-verbal pain indicators that's good for older patients with cognitive impairment. But as we can see from this multidimensional objective pain assessment tool, it looks at restlessness, rigidity, moderately restless, very restless. It looks at muscle tension. Then it looks at frowning, so much like our FLAX scale did. And then it looks for vocalization. So you're taking a lot of things that were in the FLAX scale, but then you're also looking at heart rate, respirations, diaphoresis. And so this is something that may be useful to try to use this. Now, please note that in the development of this, they excluded people who can report pain, who have dementia, or who have neuromuscular diseases, such as cerebral palsy or spinal muscular atrophy, because that tension in the muscles may not be appropriate in terms of indicating pain because of the nature of the neuromuscular disease. We have to work to find ways to overcome challenges. If there's a language barrier, we need to use a medical interpreter, not a family friend or staff member who's not trained in interpretation. We want to allow extra time. Patients that can't report but they have injuries that we think would cause pain, we want to assume pain is present if they have this condition that will cause pain and they can't report it. And we have to understand that pain reports and communication may be influenced by culture. It may be that people feel that they need to suffer, or it's not appropriate in their culture to actually report pain. So really, pain is really multifactorial, and it affects physical, affective, cognitive, behavioral, sociocultural, and environmental factors all play into the person's experience in pain. So when we do assessment, we have to do a biopsychosocial assessment and treat in the same way. So a comprehensive pain assessment really includes the following. Is there a history of pain? Does this person have a history of chronic pain, like DJ in our case study? Is there a history of surgery or trauma? What's the medication use? And really also looking at illicit use, because patients might be telling you, listen, my patient that's in the hospital now saying, yeah, I'm using fentanyl for pain, not fentanyl that's prescribed, illicit, because my pain is uncontrolled. Are they using non-pharmacologic measures? Like my patient the other day saying that he had a Reiki healing, and he had a psychic healing that he felt helped this pain. Is there comorbid depression and anxiety? And with people with chronic pain, if we're not treating the pain and the depression and anxiety, it may be hard to treat the pain. What is that person's functional status at baseline? If functionally at baseline they're not moving much and now they have a surgery or trauma, we can't expect like that all of a sudden they're going to start moving more unless they're having a surgery to actually correct a problem like a hip, for a hip replacement. Are there any associated symptoms? Like I talked about, depression, anxiety, sleeplessness, fear, hopelessness, suicidal ideation. And we should be assessing for that. In this age where a lot of people were discontinued from opioid therapy because of the guidelines that came out secondary to the opioid epidemic, some people that were using opioids legitimately all of a sudden found themselves without pain treatment. And there's been an association with increased suicides and suicidal ideation secondary to untreated pain. The other things to think about, are there adverse effects from the medications used to treat pain? And a lot of these that you see here, whether it's constipation, nausea, vomiting, pruritus, sedation, respiratory depression, are things that we usually associate with opioid therapy, but can be seen with some other medications as well. So what happens if opioids are a consideration? Now, if you're a registered nurse or staff nurse, you may not feel that this part of the assessment is within your scope versus an advanced practice nurse, but I think it's important to think that an opioid risk assessment is important. It's only one component when we think about when we're prescribing opioids and using universal precautions for opioid prescribing. And we want to conduct a risk assessment if there's a consideration not to deny someone opioids, but to create a safe plan. So there's many tools available. I'm going to show a couple on the next slides, which may be able to help you. There's the mnemonic ABCD PQRS, and this is person using alcohol. Are they using benzodiazepines or other drugs? Are we thinking about like someone who has impaired clearance, like impaired renal function, and how will they metabolize the drug? Are we dealing with someone who may have dementia, delirium, or they're a fall risk? What about psychiatric comorbidities? If we're thinking about treating pain and discharging someone with pain medications, querying the prescription monitoring program. So for our patient DJ, if someone would have looked at the prescription monitoring program, if he was getting buprenorphine from his primary care provider or another specialist, not from an opioid treatment program that doesn't have to report it, we would have seen the buprenorphine or Suboxone right on the prescription drug monitoring program. Is there respiratory insufficiency or sleep apnea? We have to think about that if we're thinking about opioids. And are we worried about safe driving, work, storage, disposal? This is a revised opioid risk tool. And 2 or lower indicates a low risk of development of opioid use disorder. Greater than 3 indicates a high risk. But these are questions that you might think about just in your interview. Is there a family history of substance abuse? This is, something I tend to use substance use disorder. This is just the way this tool uses it. I don't like to use the word abuse. I prefer to use risky use or substance misuse. Is there a personal history? Is that person between the ages of 16 and 45 or have attention deficit disorder, obsessive compulsive, bipolar, schizophrenia, or depression? All these are potential risks into the development of opioid use disorder. And so there's some other considerations if opioids are. Can that person manage the medications at home? If they're cognitively impaired or just have even mild cognitive impairment, prescribing a medication every 4 hours around the clock may not be appropriate versus a patch they can put on once a week. What's the home situation? Are there people that we're worried about, teenagers, young adults, children? Are there the ability to implement safety measures like locking the medications, or having someone help with the medications? And all these are going to be considerations. And you may be thinking that if you're assessing this person in the hospital and they're going home on opioids and you're not the prescriber, why should you worry? But thinking about, are you the one that is listening and watching and being able to talk to the prescribing provider about your worries about the home situation, or that you've heard that there's a son or the daughter that might have substance use? How can we safeguard that patient? So in this short time together, I hope that you understand some comprehensive clinical interview and pain assessment is absolutely essential if we're creating a pain treatment plan. And a comprehensive assessment includes what are other factors that may influence the experience of pain, such as depression, anxiety, insomnia, and that we can use appropriate tools to assess pain in those who cannot communicate.